Yeah, so sounds good. So as you know, my name is Dr. Cass. I got Dr. Minhas beside me. He'll be helping us out. The rest of our team, our nursing team, we have Matt on my right, who's scrub nurse. We have Mim and Michelle in the back. And we have Alicia teching the case. We have a few X-ray techs that are helping out as well. So it's a tricky case. We've got on with a 7 French system, as mentioned. We've started off with a micropuncture access site, which we're quite happy confirmed on imaging there. While we were preparing the case, we had finished off with the circumflex, and we're at the level of getting into the to the LED now. So we'll get the trap liner up. So we're starting off with a goal of wiring whichever branch allows us to. Ideally, we could get into the left anterior descending, and we would use the, you got the wire from here? The dual lumen catheter to get into the side branch. But in this case, as was demonstrated, ideal may not work out as planned. So we'll try to get whichever segment allows us, and then we'll do a lumen into the side branch. We have a few ectopic beats there. Let's get the Suzuki on here, Dr. Minhas. We've favored a 7 French trap liner here, which would simplify our life somewhat in that you can use a regular trapping balloon in a 7 French system. In fact, with the Suzuki, you can use that in a 6 French system as well. But we've chose to go 7 in case we have to escalate to a bifurcation strategy. We haven't talked much about the dual lumen catheter. I'll get this up there first, and we can talk a bit about that.
Sure.
So there's multiple dual lumen catheters, as you know, that are out there, going all the way from the twin pass family to the Suzuki, and the Suzuki is the one we've recently really favored. It has a, as all dual lumen catheters will have, they'll have a distal port as well as a more proximal side port. The distal port historically or classically is the RX port, rapid exchange port, which is the one that you'll see as the marker comes out there. We have the wire already in the left anterior descending, somewhere creeping up close to the diagonal.
Yeah, looks like it's progressing well there.
So we'll get this guy in there. Okay, so let's get a little puff there, please, Matt. Let's see where we're heading. Okay, now we'll see. And so, of course, it went into the diag, it looks like, or either that or it's hiding in the, it's playing in the aneurysm somewhere. It's one challenge of wiring through an aneurysm. So you're kind of wiring in free space to a certain extent. Can we have the torquer on here, please, Matt? Oh, actually, I think this looks promising.
Yeah, I think it dropped for you there.
Let's have a look there, Matt, please. Please, yeah. We're through somewhere, but I'm trying to avoid going to that dissection when you mentioned earlier.
Looks good. Nice.
Okay. So now we try to favor the distal LED if possible. Of course, that looks promising there. Let's have a look there, please. Yes, please. No, that's the. Yeah, it's on the diag. Oh, geez, man. There you go. It looks better. The septal. Give me a puff there, please, Matt. I think I'm okay.
Yeah.
As long as you don't prolapse in the diag. Start off with a pilot wire here. Now you could start with, you find most hydrophilic jacket wires to be a bit simpler to maneuver these bends. There's nothing wrong with using a regular wire on here. Can I have a wet, please, Matt?
Yeah, if you're having trouble, you can also bring the microcatheter down to give you support.
That's a very good
To
point.
eliminate some of the tortuosity, even the proximal tortuosity.
Yeah, that's a great point. Let's try that, see if it works. Oh, hang
Try to
tight,
hold
man.
still there, man.
Well, that went a bit easier than we we thought, so it's nice. A little puff there, please, Matt. It's obstructive now with the microcatheter, but that looks promising.
Great. Looks good. Yep.
Good. So now the trick is going to be wiring that diag. So let's get the other wire there. Now the other wire we've chosen in this case is a balanced middleweight workhorse wire. Hopefully this will play the trick for us. We'll have a look. Now this one will go through the the dual lumen side access, or as an over-the-wire style wiring process. So we have that wire going in.
You shaped this, I can see. Hey?
Mm-hmm. And when you're close, we'll pull the Suzuki back and give us more guidance. There you go. All right. Well, our lovely patient is having some discomfort.
Having some leg pain, I think. I'm cramping. Give her a bit more sedation.
All right. So let's
0.550. Thank you.
we'll pull the Suzuki back. A little puff there, please, Matt. Okay, that's close to where it is. I'm not sure she'll tolerate this much longer. Okay, let's get that in there, Dr. Minhas, if you can. Oh, don't make it look too easy.
I think that'll be a problem to make it look too easy.
Give us a puff again, please, Matt. I'll bring you back a bit.
Yeah.
We talked about this at length previously, both at our heart team meeting as well as at our interventional planning meeting, as to how you would approach this bifurcation strategy, non-bifurcation strategy, provisional stenting. Of course, in this case, we do feel that less is more. Of course, there's always the possibility that he'd have to get into a bifurcation strategy if you compromise that diagonal, which is a reasonable size.
Wire here. This is. Oh, let's see. Test there, please. Okay.
Yeah, I think the diagonal is misleading. Even with the Suzuki, we're struggling.
Yeah, it's always hard to see the origin in multiple views. We couldn't really perfectly pick it. Yeah, I think if I need should take a pilot maybe here.
Sure, yeah.
Can we get a pilot 50?
Maybe I'll pull this back a bit, let the vessel breathe here.
You could toss it out, thanks. I think the tip is gone.
So I'll just pull the Suzuki out, let the vessel breathe a bit more. Give us a little puff here, please, Matt.
Got it.
Good.
Yeah,
Thank you.
Good. Yeah, thank you. Yeah, I think here, given her diabetes, long length of stent in the main vessel, a lot of calcium, and that fact that she's going to be on renal replacement therapy, would probably be best to try to not do bifurcation stenting because she'd have quite a high risk of restenosis, particularly in the side branch.
Yeah, bifurcation strategy is always a wonderful discussion item. As to what approach you would use. First of all, do you do it? And second of all, what approach would you use? There's multiple techniques out there. One of the best data is the DK crush, the dual kiss crush, double kiss crush,
Just get the introducer there.
Which we do tend to favor here, but it does have quite a few steps, and most people at the training level always will miss one or two steps, which are actually quite vital. But for many reasons, as mentioned by Dr. Minhas, we will try to avoid that in this case and go with the provisional strategy. Okay, when you're ready, I'll bring you back down.
Yeah, go ahead.
There you go. Give us a puff there, please, Matt. Very good. Now, lining up the markers is not always easy. You want the dark marker. It's a very short RX. Come back a bit there, yeah. It's very short, rapid, short from the RX to the over the wire of about 6.5 millimeters.
A little bit more, maybe.
Let's try that out. There you go. It looks promising. With the Suzuki.
Test there, please. Yeah, we're just getting caught probably in the aneurysms, I think.
And there's a lesion there that's misleading us too.
Right. Yeah, I suspect we have to come back a little bit more if we're getting into the aneurysm with a side branch wire.
Oh, that's looking good.
Puff there. Let's just make sure we're not. Yeah. Okay. Let's see if it goes freely. There was that small area that looked like it had a small dissection.
Puff again there, Matt.
Okay.
Looks promising.
That looks pretty good, yeah. Small test there, please.
Your tip looks loose.
Yeah, I think it's good there.
All right, perfect. Well, I'll let you walk that out as you being the over-the-wire guy.
Yeah, there's a nice dual lumen catheter called Venture, which has the advantage of having a deflectable and steerable tip, which sometimes can also be beneficial for side branch access. It also gives you a bit more support. But here, this worked well for us. Yeah, it's good.
You good there?
Yep.
All right, we'll take the trap liner up. Trap liner going up. Of course, when the trap liner goes up, you lose pressure. This we can come out now. I'll mark my LED wire as a vent wire. That's interesting if you can show that somehow, how it traps air.
Right.
Every time we take the trapper out,
Yeah, okay.
see out.
It's up to the exchange port.
Okay, sounds good. So, trapper down. You have wire?
Yeah, I'll just hang on a sec.
Hang on, we're tangled a bit here.
I think you're caught up in the guide planner a little.
Yeah, let me just, hang on, I want to lose this wire. Go to soft again here. Yeah, it's just tangled on it, you're right.
Yeah, I'll just bring it back this way. Yeah, no problem.
Beautiful. Nice.
There we go, nice. Okay.
Okay, let's take the rest of it out. Okay, hang tight, don't pull yet, Matt. Don't pull. Trap liner's down. Okay, I think we can walk that off now.
You just want to flare there, just make sure it's pretty tight still. Yeah, you're just pulling the LED wire there.
All right, well, let's see. The wires must be tangled up a little
Yeah,
bit.
they probably will have to be. See, just flare. Do it under flare here. Yeah, just walk it back a bit here.
Contrast, everybody's friend.
Mm-hmm.
And the best glue out there.
Perfect. Thank you. You could just give that a flush and keep it on the side. Good.
Let's wipe these guys out. Let's get our LED wire back down.
Can you drop us a second inflator, please?
So again, as we've talked about in the past, anytime you do a trapping balloon, you always bring in negative space, so you always entrap lots of air into the system. So you always want to de-air the system as much as possible. We get our LED wire back down. There you go. Good. All right, let's get some pre-drilling going.
So we should take maybe a 2.5 NC for the LED, and then we could take like even a 2.0 compliant to start with the diag.
Brilliant. Let's do it.
So we could take a 2.5 15 or 20 NC for the LED and a 2.0 15 Trek for the diag. I think the advantage of using the trap liner here is, oftentimes when you're dealing with trapping out microcatheters, you also have issues later on during the procedure of support. So it gives you, thanks, perfect. It gives you, we'll take them both, yeah. It gives you the advantage of both. So now if we have issues delivering equipment down to the LED, we can bring down the guide liner portion to give us support. It's the 2.5? Okay, perfect.
This is the non-compliant?
Yes.
All right, so this will go in the LED. How are we doing for heparin time there, team? 22 minutes. Can we get someone peripheral to give 4,000, please?
The wire.
Got it, thank you. All right, so we have two lesions the LED we're interested in. We'll dilate our way down. That went okay.
Nice. Yeah,
all right, a little puff there, please. Yeah. Yeah, let's start there. I think that's pretty good. Let me bring it back a millimeter. Yeah, I like that.
Yeah, I think it's good. Up.
This is distal LED there, Alicia. So that dilated nicely.
Looks good.
Very good.
It's 10.
And then we'll get to the aneurysmal segment.
Yeah, and stent-wise, I think we'll land, our plan was to land a stent after that second diag, and then one long stent past that aneurysm into the proxy LED. You good there?
Yeah, I think so.
Up.
It looks a lot more forgiving than I expected it to.
Yeah.
Quite the bend.
Yeah, it's pretty aggressive bend there. Down 14, so you can see why there's difficulty wiring that. You have the severe lesion proximally, a lot of calcium, and then two quite acute bends. So microcatheter helped us there quite a bit. Up again. Yeah, I mean, this looks pretty good even at relatively low pressure.
Agreed.
That's 10. That's 14 down. Yeah, I think as we've done in other cases when we're putting long length of stent into a calcified vessel in a diabetic patient, particularly with renal disease, we're going to plan to image this and use image guided once we get it modified. So we could take the 2.0 now, I think dilate that diag.
And the IVUS is ready there for us. All right, the 2.0 is going in the diag, everyone.
You could hook that up.
This will be an interesting angulation. We'll see how that looks on fluoroscopy.
Set this up.
Can I trouble you over here, Matt, please?
Perfect.
Let's grab this guy for me. Appreciate it. Thank you. Maybe give me a bit more straight there. That's good. All right, so while we're getting this balloon up into the diag, we'll give ourselves a nice healthy inflation with the ultimate goal of avoiding intervening on it with metal. Dr. Minhas is getting the IVUS ready for us. Now let's see how this guy goes. That's not terrible, actually. Let's go up there, please, there, Matt. Take me to 20. Okay, we can come on down there. Now, just to ensure that we're not in the actual bend and the aneurysm and missing the actual diagonal, we'll go up there again, please. Give me same. Come on down. All right, let's take this guy out.
Looks quite good there with a small compliant balloon even.
Agreed. Okay, all right, I'll walk this out for you there, Matt, and then we'll get the IVUS ready. You okay, ma'am? That's a good sign.
Okay, I'll walk this to you.
All right. Let's get this IVUS over the LED wire. IVUS, of course, has a very short RX.
Oh, great.
All right.
Got it.
This is where the trap liner could really help you, especially to maneuver the initial bend.
Mm-hmm.
With this IVUS, it has a really short rapid exchange. All right, I've got the wires, thank you.
Perfect.
Our radiation markers. And let's see if we can get down past that ultrasound, that interesting lesion. It's struggling a little bit, but it's going.
Yeah, looks good.
And we care less about the distal one, so we'll skip that one.
Great.
Perfect.
Okay, let's start it up.
We'll check our... All right, so just confirming that everyone can see the IVUS on the screen. And we'll start the pullback whenever you're ready. Pullback is started. Surprisingly, that mid-LED segment, distal to the aneurysm, looks not bad.
Yeah, I mean, there's some plaque there from sort of 3 to 6 a bit of calcium now as well, but yeah, good size lumen.
Must be getting close to the aneurysm soon. There's your opening, I suspect. Are we at the aneurysm? It looks like we are here.
Yeah. Yeah, we're just across it there, yeah, for sure.
Maybe a little flush there, please.
Sure.
I can't see much there.
So now we're into that calcified proximal segment. You can see almost 360 degrees of calcium in that one spot. Quite a lot of calcium there as well.
Wow, that's
Which
impressive.
we probably, you know, every time you image, the calcium is going to look more severe than on the angiogram. But
Looks like a nice landing spot there. Some just plaque from 2 o'clock to 6 o'clock. I think you're going to get plaque everywhere in this vessel.
right. So now we're back. Okay. Good. Okay, great. So I think we can get this out.
All
So
right.
then maybe we'll take a quick look at IVUS and see what our next strategies are here.
Okay, so I'll pull the IVUS out. Maybe as I'm doing this on the fluoroscopy part, maybe focus on the IVUS screen as Dr. Minhas will work on that, give us some measurements and try to get a better look at that.
So here we are distally. We can see we've got a fairly healthy looking vessel here, as we saw angiographically as well. So we could probably pick... yeah. Yeah, so that's 5.5. And then if we come more proximally, we have into the aneurysmal segment, we see have eccentric calcium, but I think there won't be an expansion issue there. And then as we come more proximally to that segment, we have quite a lot of calcium that we probably have to modify further. So especially here, we've got almost circumferential calcium with a very small lumen. And that extends further, even proximally. And then more proximally, we have a good sized lumen. So I think this area here will probably have to use specialty balloon here to modify this. So what are your thoughts? I mean, we could go, we've only taken a 2.5 NC. We have quite a lot of calcium here. I think NC balloon is probably not going to be enough. So what do you think about shockwave versus OPN in this situation?
Yeah, I think a shockwave is a wonderful option here. OPN is fine as well, but the other option, of course, is a cutting balloon. Although cutting balloon might have some challenges making it down there, and with the wire and the side branch, it's a bit more tricky. But I would favor a shockwave balloon here.
Yeah, I would use shockwave. I think if we go with based on the sizing there, like probably a 3.0 shockwave, that'll give us a good option to expand that area because we do have quite a lot of calcium on IVUS.
Can we organize for a 3.0, please? 3.0 shockwave. Thank you.
And in terms of our distal landing zone, the area past an aneurysm, there's a plaque there. So now we have to decide, do we want to just essentially cover from distal to that second diagonal all the way back? Or do we want to leave that small gap just proximal to that diagonal? The lumen looks small in that segment. So
I agree. It looks better on IVUS, but it does look small now. Then you're talking about 3 stents here, likely.
Right.
Can't tell if the diagonal is in a dissection plane either. The wire.
Right.
Yeah. Okay. Thank you. Sounds good. Yeah. So, I think we might be forced to cover the whole thing.
I think we'll have to cover it. Looking at the IVUS, that area has fairly small lumen. Have we tried to pull the diag wire back a little bit? It's possible we're just obstructing it with flow there. Do a small branch.
All right. I wonder if we're subintimal.
It's possible, yeah, for sure. Because we did on the angiogram there was a small little flap, even though the wire went reasonably well.
Tolerating it reasonably well. So I think we're going to be stuck. I mean, the second diagonal doesn't have a ton of plaque at the ostium, so I think we'll be fine to go across that.
Right.
So we'll modify the aneurysmal segment with our shockwave, and then probably go ahead with a long 2.5 and then long 3.5 up top.
Right.
3.012, that works.
Yeah, perfect. Thanks.
Can you can we have someone on X-ray show me the cranial, please, on the pre? Show me run 6, please. Run 6.
Thanks. Yeah.
Can you show me run 6 on the old one?
Perfect.
Actually, that left main looks okay. It looks the same. That's okay.
Yeah, there's no... Another good... Yeah, I can take it. Yeah. Yeah, to you. Thanks.
All right, we'll get that going as you prepare the back end of it there, Matt. The important thing with the shockwave balloons, the lithotripsy, make sure you're de-aired as much as possible so you can transmit the pressure. And also, we don't typically go to very high atmospheres. We typically go to 4 and then finish off with 6 if needed. Sometimes a bit higher, but most of the pressure comes from the actual shockwave itself. Matt, you're prepped? You're negative? Double prep, thank you. Okay, you got the wire Dr. Minhas?
Got it, yeah. Yeah, it's interesting. We've I looked at our recent data, and we do about 2,600 PCI a year. Our use of imaging is about even between IVUS and OCT at about just over 300 each. And interestingly, over the last year, the use of OPN and shockwave is also equal. You just have to turn it on there, the bottom yellow button. So we've used about 100 Shockwave and 100 OPN balloons over the last year as well.
All right, so Matt, let's take this up to 4, please.
Okay, we're going up. 4.
All right, we can start
Yeah,
some
looks like
therapies
good
there.
balloon prep. Great.
All right, therapy's activated. I have to
Good
make that
expansion
bend as
there.
well.
Yeah.
Come on
good.
down, Matt.
It's 10. Yeah, and it's not uncommon to see these small shock topics when we use shockwave, and also a small drop in the aortic pressure, which usually always bounces back. Just watch your guide position.
Yeah. Let's get
You can bring the guide liner portion down.
take advantage of this guy.
Just watch your guide.
Yeah.
Get a bit more coaxial. This doesn't flip on you. There you go. Yeah.
That might be okay for the balloon there.
Yeah, I think you're good.
Go up there, Matt, please. 4 again.
Going up again.
Okay. All right, we'll get some therapies going. Looks not bad there as far as expansion. Now, of course, this proxy LED probably measures closer to 3.5.
That's right. Yeah.
So that's gone nicely. Let's go up there again. We've committed to a full strategy here. Therapy's on. Dilating nicely.
It's looking good there. Yeah. I think we'll have to do a bit more in the prox part, but the initial inflation in the proximal part to also look like it had good expansion.
All right, so I think we got the balloon part reasonable. The aneurysmal part anyway.
Yeah, I think that's expanded well.
Let's come out here. Deep seating the guide a bit there. Okay, let's chart that there.
Take it up. Yep.
Going up again.
Yeah, within the aneurysm, there was sort of a eccentric area of calcium, but most of it wasn't calcified, so, and we wouldn't expect to be able to oppose that portion of the stent.
Yeah, typically try to avoid stenting into an aneurysm
Yeah,
for the
here we
reasons
don't
that you
have much
mentioned.
choice.
Pressure is a bit low there. Give me a puff here, please, Matt. Let me see.
Yeah, it's quite a large
Take a
dissection
picture here.
approximately.
Good.
Yeah, large dissection
right.
there in the prox LED.
Let's get to probably put some, I think, some stents down.
I think that's a good idea. So should we go? I think
get a long 2.5.
Take a 2.538 Promus.
Yeah, let's do that.
Thank you.
Very important we don't lose our wires now.
You could use this inflator. Oh, you got the inflator off. Perfect.
That's a good point, actually. The other trick of if you're worried about losing your wire with trap liners, you can just trap up every time you pull out the balloon.
Right. Yeah. If you've got some tangling or something of your wires. Yeah, oftentimes, if I'm not having a bifurcation, I'll take the inflator off of the balloon part once I've done exchanging, and I'm just using it as a guide liner at that point.
Let's get a 3.538 ready as well.
Hey, you want to go 3.5 or 3? Because we're going to land this.
Yeah, let's go 3.
Yeah.
We can always force
make
dilate
it
that.
bigger for sure. Give you that. Perfect. Perfect. Yeah, thank you. Yeah. Yeah, pressure looks good now. I think it's just all the equipment that was in there. Yeah, I've got the wire. Yeah, thank you. Yeah, good. Thanks. Yeah, it looks good.
It's a bit sticky in there. All right, you got the wire there, sir?
Got it. Yeah, go ahead. Thank you.
Yeah, I got movement there.
Perfect.
All right.
Thanks.
Now let's see how far this goes down with some support.
The challenge of the stent architecture there to make those bends.
once you've committed to a stenting strategy,
Yeah,
makes
it's
it
looking
easier.
good, looking
Makes
great.
it easier, a bit more aggressive.
Do you want to just pull the guide liner back? I don't want to inject into that dissection plane up top.
Yippers. It's not
Happy
terrible there. Yeah.
Yeah, I think it's good. We'll take it to low pressure. Up. Yeah, it's opening. Yep, it's good. It's 10 only. So
We'll
it's good.
post dilate that.
It's down 10. Yeah, we just pull the stem plume and go to higher pressure there.
We can go up there.
Up.
Very good. Let's get a 3-0 next, please. Yeah.
14. And I think here, given the fact that we think we may have dissection of the diag, we'll just stent across and jail the wire.
Correct.
Thank you.
Oh, the lovely challenges of a calcified lesion in a dialysis patient.
Yeah. Good.
Thanks, Matt. Freezer. Let's get this guy on.
3038's going in now.
Grab it. Got it. Yeah. Thanks.
You pull back the wire a little bit.
Yeah, just a touch.
That's good there.
There you go.
All right. Let's see how easily this guy goes now.
Yeah, this shouldn't be too much of a challenge here. We've delivered that one quite distally, so
I love your optimism.
maybe I spoke too soon. Yeah, it's moving, making progress.
Slowly but surely.
Yeah.
Guy liner nice and deep here.
Great.
All right, I think that's probably in there. Yeah, I think we're in there. We're past the diag, so we're good.
Yeah.
I'll just double check that. Nice overlap. Yeah, let's go up there.
Up. I suspect we'll need a short one up top.
I think so too.
Yeah, so. I mean, that's at 10 atmospheres. Looks great.
Looks good.
Looks great, yep.
See how much room you think we'll need up top. Maybe another 12.
Yeah, 3.5 up top, yeah. It's down 12. Yeah, we're always going to have that little bend because of that calcium in that aneurysmal portion in the bend. But
So we should be okay here.
looks good. It looks
Let's
well.
get a 3-5-12, please. Stent.
So at this point, do we want to, I think we'll give a puff, see what the flows down the LED. Also look at that diag.
Correct. So we
I
don't
know
double
if we
jail.
want to double jail it.
All right.
Perfect, thank you.
Thank you. Ready, sir?
Yeah, just do a cine, yeah.
That looks pretty good.
Yeah, so
We'll get the stent in place, then we'll take out the jailed
I think so, yeah.
wire.
Looks great, yeah, it looks really good. I mean, the diag has been a big compromise, but the LED itself looks quite good.
We'll probably get our NCs ready. Get a 3.0 NC maybe down below, or 2.75 maybe.
I think we take a 3 for sure, yeah, and then probably a 3.75 up top.
Yep.
You take it longer. Do you have a 3.020 and yeah, and then you want a 4 up top?
Let's do a 3.75 to start. Yeah.
Yeah, sure. And then we could take a 3.75 20 as well. Thanks.
Got it?
Got it.
This wire is very sticky.
For sure. Yeah, I'll hand it to you. Yeah. So we just need the guide liner portion. Perfect. Thank you.
Okay, I'm not in yet.
3.020.
Yeah, wire's good. Okay. right, look at this guy in position. And then we'll take out our jailed wire. Jailed wires are off to you there, please. Yep,
Yes,
all the
you
way.
can take that out. The diag wire's out.
Okay, so let's check our positioning on the caudal. Test there, please. Oh, looks pretty good, actually.
It's a good spot. Yeah.
Let's take it.
Up. It's down 17. Okay.
We're getting somewhere here, team. We're getting somewhere. I'm liking this.
Yeah, it's a good result. And she's much more comfortable as well now, so it makes the procedure go more smoothly.
So we'll get our post dilatations early on, and then we'll do some more. We'll take the IVUS back in and see what we're dealing with. 3020 sounds good. So distal LED, we're typically in the 2.5 to 3.0 range in most patients. We've done this IVUS. We haven't gone down that far, but knowing in the mid segment that it's at least 3.0, we're going to go somewhat sensitive here in the very distal segment. But as mentioned earlier, in a dialysis patient, got the wire, thank you, your risk of ISR is so high that it's very important to optimize your lesion as much as possible. All right, so let's get this guy in there. Now making that bend is going to be somewhat tricky. We'll use the trap finder to help us.
So your balloon is getting a bit caught up in the proximal stent.
Correct, the
Yeah,
angle
it's
off top.
So we just need to pot that on the way out.
Yippers. And that angle we suspected is going to be a fun challenge.
Yeah, it's quite a cute angle from the main.
Should probably go there, not too big.
Up.
And we are missing the very distal tip of it, but
I think it'll be okay. It's going to be oversized anyway. It's down 8.
it looks like we're in the right location there. Might go in a bit more. There's a bit of a bend there.
Yeah. You could stent boost that. You're thinking the distal edge?
I think we're good now. Get a soft 8 to 10.
Up.
What do you got there?
It's 8 there. I think that's good. Down at 8.
Safety first.
Yeah, do no harm, I guess.
All right, let's go again.
Up.
Good. That's looking good.
It's 12. Yep.
Here we can
Up.
move it bigger, I think. Yeah.
Yeah. Go right here.
That looks nice.
That looks good. That looks
Okay.
16. And that's the proximal part of that balloon is in the area where we were thinking of not covering that was calcified on the IVUS, so that's expanded well.
You want to do there? Just go to the big. Yeah, we'll go
Up.
there. Very
That looks
nice.
quite good, yeah.
All right. Let's get the next NC ready there,
16.
please, Matt.
Perfect.
Matt, give me a little puff here, please.
Let's see how the diagonal's holding up under pressure.
Distally.
I don't even know if we need to do anything to it.
The diagonal?
It looks great, yeah. I mean, we ballooned it, but we had worse flow with the wire in there, so that's great.
It looks better now than
Yeah,
before,
it looks
agreed.
quite a bit better. That's great.
But sometimes you modify the lesion to modify the angle.
Absolutely, yeah. You change the angle, and you have better inflow from the main vessel. That's going to help as well. And I suspect some of it was the vessel's quite small distally. We're probably, and it's tortuous. So we're probably creating some disruption to the flow.
Now the last 3.0 got stuck at the entry into the LED stents. What we could have done is we could have walked the trap liner over it
Right.
to make this one a bit easier to get in. But that then it would make the procedure too easy.
That's right. Yeah. I think as long as you recognize that, and I think more and more we realize with partly through DK crush when you do pot, but imaging, you realize how often the proximal stent is underexpanded and we're getting caught in it. But I think people are more cognizant of not concertinaing or accordioning that up.
Oh, look looks pretty good there. Looks like
Looks
it's giving.
good. $15.
Should we make the bend? I stayed away from the bend on purpose with a 375.
Yeah, you could just put the balloon into the aneurysmal part because that's quite large. I think we don't have to
There
go
you
too
go.
much around it. Up.
That looks nice.
Yeah, it's 14. I think let's see on the IVUS that the stent is probably expanded, but we're not going to be opposed, which we wouldn't expect in that aneurysmal portion.
Yeah, it looks good. Can you get another 4, please? Yeah, it looks like it's good there.
I think good, yeah. Up.
Yeah, I'm liking that as well. Bit of ostium left behind.
Right. It's 14.
Give me a tiny puff, please, Matt. I think we're there, actually. Yeah, I think we're there.
I think we're there, yeah. You want there?
Yeah, sure.
Up.
Yeah, that looks good. Yeah.
16.
All right, let's let that sit there. Let's go back to the cranial.
Yeah, I think we could give a small puff. Flow looks good, looks expanded. We could just IVUS it at that point.
Yeah, let's wire. Let's take this guy out there for what it's worth, and then I'll get the wire in a better position for you. We'll get the IVUS ready, please, Matt. The data for IVUS, or at least imaging guided, is fairly strong now across all vessels, not just in the left main stem. Making this bend might be somewhat tricky.
That looks quite nice.
Although I will take a knuckle.
That should help you. There you go.
Theoretically.
Yeah. Thanks, Ian. Thanks. Yeah, you just go to...
Do you have a torquer there, Matt? Can I have it, please? My hands are sticky now. No, it's good. This wire is quite happily done its job, but it's starting to struggle a bit.
There you go. Nicely done.
Where are we down there? There you go.
Just, oh, I think you're into...
Yeah, that's an septal. And hopefully just that.
Yeah, maybe just...
Stay away from that area.
Yeah, I think that's... Yeah, it's pretty small down there.
All right, ready with the IVUS?
Yeah, perfect.
Matt, can I get a dry, please? Oh, this lovely contrast.
Okay, coming to you. Yeah, got the wire.
Maybe more rail there if you don't mind.
Oh, sure. Just sorry. Hang on. Here. There you go. Thanks.
Very good.
Okay. You could just hit a new record there, please.
All right, can you come with me some more? What's wrong with our pressure there?
It's probably off.
What happened to our pressure, guys?
You'll have to check maybe the manifold's off there.
Check our pressure, guys, please. Did it come off?
Oh, here, let's close this a bit too. Here we go. We're back.
Too open.
Yeah. I might have to open it a bit more there.
Yeah, no. All right.
Yeah, that's a good sign. You're getting the soft IVUS catheter to pass all the way down that calcified tortuous segments.
Let's see if we can
Yep.
give this guy a bit, give us a bit more push without concertinaing the proximal part. The RX, of course, is very soft. We can probably start there. It'd be nice to get a bit deeper, but because we're right at the lesion here. Let's see if I can get this guy in. Should fit in a
There you go.
375. There you go.
Yeah, I really like use this is a good good example how many times we've had to use the guide liner portion of the trap liner here in this case just for small little things to make the case go a bit smoother for us.
Okay. All right, we're flushed. Okay. All right, ready for fullback?
Great. Drop the lights.
Pull back on. So that stented segment looks undersized.
Yeah, we can see there on the from 6 to 9 we've got eccentric calcium there.
1, 2, 3. That's 3 millimeters. Get that 3.0 back up down there. That's distal to the second diagonal. That's unopposed as well there too.
Yeah, again, it's quite eccentric calcium. So, and there's quite a lot of calcium there in the
1, 2,
top
3.
left quadrant.
It's a 4 millimeter vessel.
Yeah, and eccentric calcium there on the left side of the screen.
It's interesting because you don't see the aneurysm. We're past it. We're in the prox.
Yeah.
Covered it up nicely with all the calcium misleading as well.
Yeah.
Yeah.
Yeah, I think the shockwave, we focus the shockwave there. That's done
that's undersized there too.
Yes.
Or unopposed anyway.
There, but yeah, just in the very, that makes sense. It's quite a large vessel. Probably could take a short 4.0 to the prox stent and then come back with a 3.0. Here, you know, we've got a good result. We're going to try to optimize a few spots. And you also have to, when you have a calcified vessel, you've got good MSA and expansion. You also have to balance that with going back with higher pressure balloons. You know, obviously the risk of rupture. But yeah, I think we can optimize those couple spots. And really, the proximal, very proximal part is just really an apposition issue. It's not an expansion issue. It's not limited by calcium. So should we take a fresh 3?
Let's take the 3.0 down below first.
Yeah.
And then we'll take a 4.0 balloon, please. Give us a 4.0 NC.
Yeah, we'll take a 4.08, 4.12 NC would be good.
Yeah, 12, 15, wherever you have something good. Yeah, we'll take the 3.0 NC back, please, there, Matt, the 20.
Yeah, here we go.
All right. So
yeah,
again,
it's more calcium than we probably expected distally. So again, we had just taken an NC there. So it shows you how much lesion prep out you have to do in these cases oftentimes.
We'll take the same NC down, which will be a bit more aggressive.
Yes, I think so.
I think she's comfortable.
Got the wire. It's going to go distal. Thank you.
Good. I think what happens, the entry was stuck.
Right.
All right, let's see if we can get that guy down a bit better. $12, please.
12's good, yeah. Thank you.
All right. That is struggling with us.
So we can take a fresh one.
Yeah,
Yeah, can we get fresh 3020 NC, please? Yeah, this one's
this one's done.
been used a few times, so thanks. Thank you.
Any luck? Sure, we'll make it work.
So the balloon is getting stuck. Where do you think the RX portion? Or
Yeah. Get a towel, please, there, Matt, if you have one.
great. Yeah, I think that makes sense because the balloon's been used, and so it's trying to get through that port. It's going to get.
Yeah, we'll go with the 3.0 again in the distal segment. Thanks, Matt. And then we'll take that 4.0 in the prox mid segment. Beautiful. Good wire, sir.
Thanks.
All right, here we go. So just hit the bend as expected.
Yeah, it goes much easier for sure.
I think we could probably come back a millimeter there.
Yeah.
Start there if you don't mind.
Okay. Up.
Give it a good 12. It's growing slowly.
Yeah.
That's 12?
Yep.
Yeah, it's undersized, isn't it?
Yeah. Okay. It's 12.
All right.
Up.
That looks more like a 3.0 there.
It's probably been here in the proximal. Yeah. It's 14.
Give us a map, puff your map, please. Make sure we behaved ourselves down there.
Looks
Okay,
good. Yeah, looks good. Up.
Looks good.
16. That's good. Yeah.
Should we go with 4 from now on?
I think so. Yeah. We could bring the guideliner back too to let her. Not all the way, but let her breathe a little. Okay, great.
All right, let's get that 4.0. This is where the imaging can really help you. Never at the start of this procedure, you'd never imagine that would be a 4.0 vessel.
That's right. Yeah, we were actually when we were looking at the pre-planning, we were thinking of putting a small 225 stent distally there. So yeah, I think it shows you when you stent in such a long length, it's going to look fairly symmetrical. So it's oftentimes angiographically hard to figure out small areas that are underextended.
You.
I think the IVUS and the OCT really help you with that to optimize your results.
It'd be interesting to know what colleagues in the world do, whether they select one over the other, and why.
Right.
You probably start soft there, I think.
Yeah.
Right
Up.
at the aneurysmal segment. Yeah, we'll get the guideliner back in. All right, there you go.
10.
Going very aggressive here, up to 10. It's getting stuck at that bend a little bit there. Let me walk out with the guideliner.
Yeah, it's probably just deflating there.
Okay, go ahead.
Up.
It's looking better.
Yeah, that's pretty good
Yeah.
going.
Looks good.
It's 12.
We'll do one more here, then we'll go to the caudal, make sure we're done nicely.
Yeah, we could even
Going great, ma'am.
we can stent boost if we need to make sure we get that edge. Up.
Yeah, looks pretty good.
15.
All right. Let's do a dry cine here. Looks like we're slightly outside of it. That looks better there. Go ahead there.
Up. Yeah, a lot of nice tools coming out with this software to help you
That's good.
identify these things. Small edge, make sure you're inside the balloon, the stent marker with your NC balloon. Focus in your X-ray field. So, 15 there. I'll probably give it a puff and then just do another IVUS run, make sure we've got it optimized. We've got a few minutes left here.
200. Look at that nitro here. 200 nitro, Alicia.
Get the IVUS back, please.
Give us a little puff here, please, Matt. Oh, it's looking pretty happy there.
That's good.
That's good.
Sorry. Sure.
Hello, doctors. This is Danny at Main Controls. How long do you still need to finish that case?
We probably need another 2 minutes, maybe.
Okay,
that okay?
because we're supposed to be playing that back at in like 7 minutes. So whenever
Sure. We'll do a quick IVUS run, and then you could.
How much time do you need to? How much time do you need to edit there, Danny?
we can't edit it in 7 minutes, to be honest. So whenever you finish, we'll delay the transmission to be ready for playing it.
All right, perfect.
Sure.
Just give us another few minutes, please. Yeah. Let's go on myself now. Look at that.
Yeah. So obviously, we've modified whatever needed to get a couple of airings. Yeah.
All right, we have a new run
Hit
ready.
the live record there for us, please.
Okay, good.
Thank
Let's
you.
spin it.
Let's trigger this pull back here.
Isn't that amazing? Still, looks like I could use some more, but I think we're good.
Looks quite good there. Yeah.
Some reasonable opposition
Slow
there.
for me for a sec.
See where we are.
Yeah. Yeah. Thanks.
Where are we here? This part looks small.
Yeah. There's eccentric calcium there for sure in that small segment. Yeah. Yeah. Right about there's an aneurysm. Yeah. Yeah, you can kind of see that.
Yeah,
It's not fully opposed,
but
we
as you
would
mentioned
expect it
earlier,
to
that's aneurysmal, exactly. Yeah.
yeah, it looks quite good there. Again, there's calcium. So, when you have eccentric calcium like this, it's going to be challenging to, you're not expecting, I think, to get it completely symmetrically opposed. You're just looking to get as big a MSA as you can here. And that looks quite nice there. It's quite large.
That part looks good. Yeah.
Yeah.
Very good.
Great. Yep, that looks good. Nice result. Yeah. Again, we're trying to get the best result we can for any patient, but when the risk of restenosis is so high for a patient like this, and there's really no other option, we want to make sure first time we do the procedure, we optimize as much as possible. So we've done a nice job here, wiring the side branch, protecting a large side branch, avoiding two-stent technique there, and then calcium modification to really get a great optimization before stenting, and then using imaging pre and post to really optimize the results. So it's been a good case.
A little puff there, please. Okay, all right, we'll take this wire out. Let's have a picture here.
Yeah, good. Great result.
That looks pretty good, my friend.
That looks really nice. Yeah, that looks really good.
That looks pretty good.
That looks great. Yeah, great job.
Good job, everyone. Good job, team.
Great job.
Okay,
Guys.
great. Yeah, so thanks everyone for joining us. That was a great case. Very challenging. Lots of challenges, as mentioned by Dr. Minhas. Lots of tips and tricks. We hope this was beneficial. Again, on behalf of the team, thank you for watching, and we'd love to hear your comments. Signing off from Winnipeg.
Great.